Hey everybody, today we're launching a new video series called All You Need to Know. These are going to be short, just 5 to 7 minute long videos that will cover high yield, easily digestible tidbits that should be relevant to your daily practice. Okay, so for our first video, we're going to be talking about D-dimer and all you need to know about D-dimer. So the first thing you need to know about D-dimer is what it actually is. If you don't know what a test is and you don't know what the results are actually telling you, then you shouldn't be ordering it. Now, to understand D-dimer, we have to first review hemostasis, or the process by which we form a clot. Now, the initial event that kicks off the process of hemostasis is vascular injury. Typically, this intact endothelium is smooth and slick and serves as a physical barrier to some of the subendothelial proteins just beneath the surface. Now, these subendothelial proteins tend to be very sticky or very thrombogenic, procoagulant. Okay, so as soon as you have damage, the stickier proteins start to interact with the platelets, and there are several factors at play here, but ultimately you're going to get platelet aggregation and platelet adhesion at the site of the injury. Now, there are a lot of proteins involved in this aggregation, but just a couple of side notes that I find interesting is that one of these factors is what we call von Willebrand factor, and that helps the platelets adhere to one another. And so you can imagine in somebody who's deficient in this factor, i.e. somebody with von Willebrand disease, is going to have trouble forming this platelet plug at the site of vessel injury, and therefore they're going to have a higher propensity to bleed. Another factor involved is this P2Y12 protein. This is the receptor that some of our antiplatelet drugs target, such as Plavix and Brilinta. Again, you can see how if the drug's in your system, you're going to have difficulty forming this platelet plug. Okay. Now, the formation of this platelet plug is what we call primary hemostasis. Now, if there is a term called primary hemostasis, then that means we got to have a secondary hemostasis, right? So I'm not going to go through this entire cascade, but really all you need to know is that vessel injury, which is where the surface contact comes into play, occurs, and that goes through this entire coagulation cascade. There's the intrinsic pathway and an extrinsic pathway and a common pathway. Really all you need to know is that ultimately you're going to have formation or conversion of fibrinogen into fibrin. All right. Now, fibrin is what helps form this mesh around the platelets. Okay, so this fibrin mesh that is integrated within the platelet plug, or the formation of this fibrin mesh, is what we call secondary hemostasis. Now, in a healthy patient, just about as soon as hemostasis starts, you have initiation of fibrinolysis, okay, and activation of the fibrinolytic system, which is responsible for the breaking down of clots. Now, it's important to have these two systems in constant balance in order to prevent clots from getting too big or forming when they're not supposed to. Now, here is our cross-linked fibrin that we were just talking about. This is formed via secondary hemostasis around the platelet plug, and through the process of fibrinolysis, you have the breakdown of this fibrin mesh. Okay, there are a lot of proteins involved here. Plasmin is one of the key proteases, and that's actually what breaks down the cross-linked fibrin. Now, it doesn't cleave it nicely. It kind of cleaves it into all these different products, all these different polymers that we call fibrin degradation products. One of these is D-dimer. Now, it gets its name because it's a two-part polymer, i.e. a dimer, and it contains two of the D protein domains, i.e. there's your D-dimer. So when you're ordering a D-dimer lab, this is what you're actually measuring, which is a byproduct of the breakdown of fibrin. Now, D-dimer is technically a measure of fibrinolytic activity, right? We just talked about that. But in clinical practice, we kind of use it as an indirect measure of hemostatic activity. And it's a safe process to do that because, as I mentioned, in a healthy patient, these should be in balance, right? Okay, so that was the first thing you need to know about D-dimer, and that is what it actually is. Now moving on to the second thing you need to know, and that is when to order a D-dimer. Okay. Now, anytime there's clot formation, D-dimer should be elevated, right? It doesn't or shouldn't matter where that clot is. It can be in a deep vein, i.e. a deep vein thrombosis, or it can be within the pulmonary vasculature, i.e. a PTE. Now, we need to talk about these two entities because we think about them a little bit differently. Okay, so if you're worried about a DVT, you just order an ultrasound, right? It's sensitive, it's specific, it's inexpensive, and there's really no major apparent cons. Okay. Things aren't so straightforward when it comes to a PTE, right? So first you got to assess your pretest probability. We commonly do that through the Wells score, which gives you an idea of whether or not your pretest probability is low, moderate, or high. And again, pretest probability is the likelihood of having a particular condition before you order a test to confirm the diagnosis. Okay, so if you're worried about it, you calculate a Wells score, but then you got to think about renal function, and finally you're at the point where, well, maybe we should consider a CT angiography. Now, a CT angio is a great test in terms of it's very sensitive, it's very specific, and it's great at identifying alternative diagnoses. So a patient may not have a PE, but now we can look into other reasons as to why they may be dyspneic or tachycardic, febrile, tachypneic. So it's a great test in terms of its pros, but there's also pretty significant cons too, right? So you have to worry about contrast exposure, not just from an anaphylaxis standpoint, which can be, deadly. You have to worry about contrast-induced nephropathy. You have to worry about radiation exposure, and it's costly. Okay. So that leads us to ponder the question, wouldn't it be great if there was a lab that we could order to help us out in these situations where we really don't want to get the CTA? In comes D-dimer. Now, the problem with D-dimer is that while it certainly should be elevated whenever you do have a clot, there are also a number of other conditions which can cause it to be elevated, such as recent surgery, recent trauma, DIC, pregnancy, malignancy, liver disease. In other words, D-dimer is very sensitive, but it's not very specific. So because of that, there are only certain clinical situations in which it's actually helpful. So the key take-home pearl here is knowing when to order the D-dimer. In the setting of low pretest probability, a low D-dimer effectively rules out a PTE. In other words, if you feel fairly strongly that the patient does not have a PTE, but you really want to be sure, then a low D-dimer is reassuring and effectively rules out a PE. On the flip side of the coin, you got to know when to not order a D-dimer, and that's pretty much any other time. Okay, so if you've got a high suspicion for a PTE, then the dimer level, whether elevated or normal, is largely worthless and should not influence your decision making. So another way of saying this is if you're worried about a PE at all in a patient, don't order the dimer. It should be a test order to reassure yourself that there's not a PTE, as opposed to the first diagnostic step in thinking about a PTE before you move on to the CT angio. That's not how you should be using it. Okay? All right, everybody. That's all I got. Thanks for watching.